and welcome to tonight's webinar. This evening, I am excited to bring you the next session in the Immune Deficiency Foundation's Ask the Expert series. You'll hear a brief presentation followed by a more in-depth Q&A opportunity. Tonight's featured topic is primary immunodeficiency and autoimmune disorders, led by Dr. John M. Rudis. We will learn more about the correlation between PI and autoimmunity and how to manage associated complications. My name is Emma Mertens, and I'm the Program Manager of Community Health at the Immune Deficiency Foundation. On behalf of IDF, we thank you for tuning in to this virtual event. We created this webinar series knowing that life with a primary immunodeficiency can be complex. By focusing on our audience's ability to ask questions, we create a learning environment where our community members can guide us on what's most important in their journey. That will be our focus for tonight's program. Before we dive in, I'd like to share some emerging data from our 2024 National Patient Survey from this winter. Of the 1,178 members of the IDF and PI community who participated in the survey, 32% reported being diagnosed with an autoimmune disorder before being diagnosed with a PI. On average, they were diagnosed with an autoimmune condition at 36.8 years of age and diagnosed with a PI at 49.5 years of age, a gap of nearly 13 years. And we wanted to share this figure because I think it really demonstrates how important a topic this is to our PI community. And we're excited to share more about our patient survey in the near future. All right, here are a few items to keep in mind for the webinar. This evening, we are using the Zoom webinar feature, and attendees should be able to see the slides and hear the presenter and host speak. Attendees will not be able to activate their video camera or their microphone. That means all your questions will need to be typed in the Q&A box in the control panel of your screen. They will be read aloud on your behalf. As you begin to brainstorm questions, please keep the following in mind. Questions should be relevant to today's topic. Questions that don't pertain to today's area of focus should instead be submitted to our Ask IDF platform. More information will be provided at the end of the program on how to do so. Additionally, questions should not contain any personal health information, which includes things like medical history or lab results. We ask that no questions be submitted that name specific brands of medication, providers, or healthcare institutions. A brief disclaimer. Please remember the information presented during this meeting is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational event. This webinar is made possible by our wonderful sponsors. It is due to their partnerships and contributions that we can provide programs like this for the PI community. Please join me in thanking today's sponsors. And now I am so pleased to introduce our presenter for today. Dr. Rudis is Professor Emeritus of Pediatrics, Medicine, Microbiology, and Immunology at the Medical College of Wisconsin. He was the principal investigator for the Wisconsin statewide newborn screening program, the first in the nation to screen for severe combined immunodeficiency, or SCID. He has a longstanding interest in lung disease and primary immunodeficiencies and was first to describe granulomatous and lymphocytic interstitial lung disease as a unique disease that occurs in CVID and CVID-like disorders. More recently, his research has focused on the successful use of immunosuppressive therapy to treat this disorder. Dr. Rudis is the past president of the Clinical Immunology Society and received the CIS Distinguished Service Award. In addition, Dr. Rudis was a valued member of our SCID Compass Steering Committee and is a longstanding member of IDF's Medical Advisory Committee. Welcome, Dr. Rudis.
Thank you.
All right, just give me one moment while I pull up your slides, Dr. Rudis. All right, take it away.
All right. You got my slide next. I'm seeing the picture of me in the slide, today's presenter. There he is. Okay. Next slide, please. So welcome everyone. I had a chance to just briefly scan the attendees. I see some patients of mine. Everyone, welcome. It's great to see you, or I'm glad you're able to attend. I think our goals first are just to give you an idea of what autoimmunity is, how we define it, and how does our immune system normally prevent autoimmunity. And sort of what is the relationship, as you just heard from Emma, there's a strong correlation between autoimmunity and PI. And so what is that? In particular, early onset AI. And then more general, without getting into specifics, I'll give you one specific example of a disease, the granulomatous and lymphocytic interstitial lung disease, how we used immunosuppression to treat that. And then we'll just entertain questions. Next slide. So our immune system has a tough job. And basically, if you think about it, you've got T cells and B cells coursing throughout the body, and they've got to be able to distinguish self, which means all those proteins and things that our body produces, from non-self, like viral proteins. And that sort of distinguishing self from non-self is called tolerance. And when tolerance breaks down, that's when you get autoimmunity. And autoimmunity is characterized by antibodies and T cells that are directed against self proteins that, for one reason or another, they were not tolerized to. Now, it gets a little fuzzy, and you'll hear this as we go along in the talk, but there are diseases like MS that we classify as autoimmune, but it's not exactly clear what the self-antigen is. Some autoimmune diseases, we have a pretty good idea. Some we don't. Next slide, please. So why do we have the potential to create autoimmune responses anyway? I mean, it just seems crazy. Because we have to have the ability to recognize every single possible pathogen that exists and pathogens that have never existed before. So as you recall, we have never seen COVID-19 before, 2019. Therefore, our immune system never encountered that pathogen. And furthermore, as we know that COVID's evolved into new variants, and our immune system still has to recognize that. How can we do that? We could not possibly evolve that fast. Next slide, please. So our B and T lymphocytes have the ability to make really hundreds of millions of different receptors. And each one of those receptors sees one specific thing that we call an antigen. And these are even antigens that we've never encountered before. So we have all these T cells and B cells coursing around in our body, just on the search for these potential pathogens. In this amazing diversity on our receptor repertoire allows our ability to recognize self-antigens and foreign antigens and even new pathogens. Now, ideally, our immune system only recognizes and generates an active immune response to foreign antigens. So that's the ideal. Next slide, please. So we're going to go back to tolerance, and there's two major forms of tolerance when we're talking from an immune standpoint. T cells are made in the thymus, and B cells are made in the bone marrow. And a normal thymus and a normal bone marrow prevents most functioning autoreactive T cells and B cells from getting out. And there's a variety of ways to do it. They may just simply kill the reactive cells in question, or they may there's other mechanisms where they can get out but can't do anything. But basically, that's central tolerance. In other words, if you make a T cell, it exits the thymus, it, in general should not be autoimmune. But as we know, life isn't perfect. And sometimes autoreactive Bs and T cells get out of the thymus and bone marrow. And so we have to have a fail-safe mechanism to do that. And there are several fail-safe mechanisms that don't occur in the bone marrow and in the thymus, and that's called peripheral tolerance. And so that's just sort of an overview of how our immune system does this. First check is central tolerance, and that's in the thymus and bone marrow. And then the second check is peripheral tolerance. Next slide, please. And so this is just a schematic showing, a bone marrow and a thymus making B and T cells. And probably from a T cell standpoint, one of the most important things that gets generated is a regulatory T cell, and that's an important part of peripheral tolerance, although there are several other mechanisms. Next slide. So are there disorders of central and peripheral tolerance? There are actually many, but the classic one is this very rare disease called autoimmune polyendocrinopathy and ectodermal dysplasia. And they have autoimmunity to the parathyroid gland, the adrenal gland, and they also get this very strange infection that just involves, generally the hands, the feet, and mucosal areas, but is almost never invasive. And this is due to a gene which has been discovered called the AIR gene. And if you think about it, you're in the thymus. How does the thymus educate all the T cells that it's generating to every possible protein it could see in the body? And the AIR gene is responsible for actually making the thymus express certain endocrine antigens so that the T cells can be educated, not, damage endocrine glands. And so if you don't have the AIR gene functioning properly, those autoreactive T cells get out and you have a breakdown in central tolerance. Now, peripheral tolerance might be something that you've heard before. It's called IPEX, immune dysregulation, polyendocrinopathy, enteropathy, and X-linked. And this is due to a damaging mutation in the FOXP3 gene. And that leads to a lack of functional Tregs. Remember, I told you that Tregs are really important in peripheral tolerance. And if you have what we call a fully penetrant mutation, damaging mutation in the FOXP3 gene, this is life-threatening. In the patients, it needs to be recognized very, very early on in life. And an hematopoietic stem cell transplant is life-saving. And these infants can do very well if the diagnosis is made appropriately. Next slide. So when you think about autoimmunity in PIs, there's some autoimmune, there are some PIs that have more inflammation and less infection, and that would be like IPEX. Now, they can get infections, but some of the infections they get is just due to the autoimmune response that can damage mucosal surfaces and cause a breakdown in barrier and other things. And some PIs have very limited autoimmune manifestations and limited infections. And that would be the ABACID that we just talked about, or another condition known as ALPS. But as everyone knows, and probably the majority of people here that are interested in autoimmunity probably have CVID or know someone that has CVID. And that's pretty much what most PIs are. You have infection and the risk to autoimmunity. Next slide. So how do we treat it? You think, in most cases, the people are immune compromised that have PIs. They can get infections. So, immunosuppressions in patients with poor immune systems can trigger infections. However, some of the treatments that we use are really very well tolerated, in particular if you're on immunoglobulin replacement therapy like rituximab, which depletes B cells. But generally speaking, we treat autoimmunity in PIs the same or similar way that we treat autoimmunity without PIs. I would say one exception is in PIs, when we don't have a good treatment and the patient has a good match, we will go to hematopoietic stem cell transplant earlier than a lot of the people that have quote unquote, no immune deficiency. Next slide, please. So what is the relationship between early onset autoimmunity and the development of a PI? And Elaine, next slide, please. And Elaine Fisher's group in France has really done incredible work on this. And it's really certainly guided the way I look at early onset autoimmunity and the performing genetic testing in patients early on. Next slide, please. So this was the first study that actually looked at a broad range of PIs, and their patient cohort was very large. I'm not giving all the specifics on that study, but they looked at all PIs and all autoimmunity and tried to come up with some general statements. And similar to what you heard early on in people that are in the IDF and have a PI, about a quarter had at least one or more AIs, autoimmunity. In CVID and combined immune deficiencies, that's usually when it's a T and a B cell affected, are at the highest risk. And CVID really has a high risk of autoimmunity. Now, in CVID and in combined immune deficiency, cytopenias are the most common. And out of the cytopenias, by far and away, idiopathic thrombocytopenic purpura, or ITP, some people call it autoimmune thrombocytopenic purpura, is the most common. But interestingly enough, the onset in children carries a much higher risk of developing a PI as an adult. And we'll talk about that. And the other thing that this study pointed out is if you have autoimmunity and a PI, you are at higher risk to have a bad outcome. Next slide. So here's just some common autoimmune complications in PIs. As I mentioned, autoimmune cytopenias are by far and away the most common. GI disorders, things like Crohn's-like disease or inflammatory bowel disease. Some liver problems are also common. Skin problems, rheumatologic disorders, and others are also fairly common. And I just eventually just cut the list off because there is a number of them. The one thing I would like to point out is that if you consider things like the GL-ILD that occurs in CVID patients, it occurs much more frequently than is reported, like in registries. And that's simply because despite the fact that, we continue to tell physicians if a patient has CVID, they should get a CT scan to screen for lung disease. Still, it's still not done enough to pick up the lung disease that we see in CVID early. Next slide. Here's the slide that just blows me away. If you look at the relative risk of developing an autoimmune complication, if you have early onset autoimmunity, for autoimmune hemolytic anemia, it's over 800-fold. which just is mind-boggling. And then the other ones, like any cytopenia, inflammatory bowel disease, all these others, have a real risk. I mean, you think about it, any cytopenia is over 100-fold risk, but autoimmune hemolytic anemia, to me, and I tell my pediatric colleagues, if you have a kid that has autoimmune hemolytic anemia, you should be aware and look for PI later on in life. Next slide, please. Furthermore, if you have autoimmune hemolytic anemia and autoimmune thrombocytopenia, about 60% in this cohort had a mutation in a gene that caused PI. So our rule of thumb, even before everyone was getting sequenced based on this paper, was if you have two autoimmune cytopenias, you need to be sequenced because we want to know the gene. Next slide, please. So next, I'm going to just briefly talk about some non-infectious complications in CVID. Next slide. So everyone knows CVID is the most common life-threatening PI, and there's over 60 different genes now that can cause CVID or CVID-like disorders. And depending on the cohort that you select to sequence, 10 to 30% may have a damaging mutation. But the percentage of patients that have a damaging mutation is increased in patients with autoimmunity or these so-called autoimmune non-infectious complications. And really, in CVID, it's not infection anymore that is a problem. It is the non-infectious complications that really have been problematic. And as I mentioned, autoimmune cytopenias are the most common complication, but we can usually treat autoimmune cytopenias and CVID without much of a problem. Next slide, please. And Charlotte Cunningham-Rundles, a long time ago, published this study in Blood. It's 12 years ago, but it still points out that if you have certain autoimmune complications, you are more likely to have a bad outcome. Now, I would say this is 12 years old, and I don't think this reflects our current ability to treat these. There has been, in my opinion, substantial progress in this. But as you might imagine, if you have a lymphoma or these weird forms of hepatitis that you can get in CVID that are they're not an infection. If you have GLILD or the lung disease that I study, if you have enteropathy, these are all things that can be difficult to treat and at least in the past contributed to excess mortality. Next slide. One other thing I want to mention is some of the things I mentioned MS, but some of the things when we say non-infectious complications, we sort of think they're autoimmune, but we're not sure. And I would just say things like the GLILD, for example, in CVID, we treat like it's autoimmune, but we've never identified an antigen or infection yet for certain. Next slide. So I'm not going to go over a lot of GLILD, except to say, over time, it's become apparent that as many as 30% of patients with CVID will develop interstitial lung disease at some point in time in their life. In untreated, this leads to end-stage pulmonary fibrosis. Next slide. And this is a recent study that we published late in 2021 on the patients, all the patients that had treated, that we treated at MCW. And it was all the patients that had completed treatment, in other words, not all the patients that we saw. Next slide, please. And I just want to point out, this is a disease predominantly of women of childbearing age. 2/3 are female. In the onset, even though it doesn't look like, age of GLILD, diagnosis 36, but when you talk to these people, they had problems a decade before. at least. And the other thing that's surprising is autoimmune not surprising, autoimmune cytopenias, most that occurred before that, were present in 72%. Next slide. So when I first described this disease as some unique disease in 2004, it really had quite a striking effect on mortality. And the median survival was 30 years. It was CVID without GL-ILD and half of that with GL-ILD. Next slide, please. And, we started treating with rituximab and two other, either mycophenolate or azathioprine. And in this study, of 39 patients, the Kaplan-Meier curve is completely different. We've had long-term survivors that have not relapsed. And in fact, 75% of our patients had sustained remissions with treatment. And when we treated and they relapsed, we were able to treat the relapse. Next slide, please. So in summary, autoimmunity is a breakdown in central or peripheral tolerance. It's common. Early onset is a risk factor to develop PI in life. Some autoimmune disorders are associated with decreased survival. Disorders of immune regulation, that are common in PI and no antigen defined. Sometimes you'll hear this immune dysregulation or immune disorder of immune dysregulation. That just means we aren't smart enough to know exactly what's triggering the disorder and what's sustaining it. And then finally, on a positive note, and this is really important, I believe there has been significant advancements in the treatment of these disorders in PIs. So there's, thanks to the support of IDF and other organizations who have helped with providing funds for research, real progress has been made. And then I'll stop and take questions. Next slide. Resources. I put some resources down here. The Immunodeficiency Foundation has a series of excellent articles on this. There's also the Autoimmune Foundation that has patient-focused sites, but it's not PI-oriented. And then some general references on subjects that I discussed earlier. Okay.
All right, wonderful. Thank you so much, Dr. Rudis, for that super important information, and then also for sharing those resources at the end. All right, so we now have some time set aside for audience Q&A. If you would like to ask a question, please enter it in the Q&A box in the control panel of your screen. Please remember that Dr. Rudis will not be discussing individual cases or recommending any specific treatment. And now I am so pleased to welcome Colleen Brock, our Manager of Medical Programs, who will be leading tonight's Q&A. Welcome, Colleen.
Thank you, Emma, and thank you everybody for being here this evening. That was an excellent presentation, Dr. Rudis. Greatly appreciated. So we have some very good questions, and we will try to get through as many as possible in the time that we have. So the first question we actually get quite often: when someone with a PI has blood work done for an autoimmune condition for diagnosis purposes, how accurate are those blood tests? An example given was rheumatoid arthritis. If they are not accurate, what tests should be done?
So for some autoimmune diseases, the testing can be, quite accurate. But, for example, if you can't make an antibody like CVID, but we know patients with CVID can get, for example, rheumatoid arthritis, those tests are not going to be as sensitive. And then we rely on the skill of the of the physician to make the diagnosis based on other clinical findings, which are pretty characteristic for rheumatoid arthritis and lupus and things along those lines. So we, in general, for lupus, for example, not one specific test, like if you have a positive ANA, will mean that you have lupus. So there's a series of clinical criteria that people use to help make the correct diagnosis. So just having a physician that's skilled in autoimmune complications of PID is probably the most important thing. I can't stress that enough. And, as you know, everyone here knows there aren't enough physicians that have been trained in PI. We need to get the word out that this is the best job you could ever possibly have, and with the best patients. Yeah. All right.
So the next question is, does IG therapy offer protection to someone from developing an autoimmunity condition if they have not been diagnosed with one at present?
No, it doesn't. So, for example, the patient, if you think about it, there are a lot of patients that are, it depends. Europe and the United States are a little different when you develop CVID. In Europe, for a variety of reasons, there's a larger cohort of patients that develop it earlier on in life. And in the United States, it tends to be a little later. They're on gamma globulin and they still develop these non-infectious complications. So unfortunately, it doesn't prevent that. I would just say, for the most part, when you think about immune globulin, what it's really doing is preventing infection, which back in the day when I first started training, we had one gamma globulin that came out when I was like a resident. And, it's transformed how we treat CVID and other antibody disorders. People were dying of infection, and not many people could tolerate IM intramuscular gamma globulin. So, again, it's an example of how things have gotten better, just not fast enough.
And that slides right into the next two questions. Address the connection of persistent chronic infections as related to autoimmune diseases and PI. And the other person asked, what impact, if any, does the presence of an autoimmune disease have on your susceptibility for contracting infectious diseases?
Those two questions are a little interrelated. So if again, if you're thinking about how we treat autoimmunity, usually we're using the same medications that are in our patients as we use to treat autoimmunity in people that don't have immune deficiency. So, for example, like in CVID, one of the most common complications, autoimmune, is autoimmune thrombocytopenia or idiopathic thrombocytopenia, ITP. Initially, usually we try steroids, but sometimes, not infrequently, it can come back. And so those patients will get rituximab, and in a way, it depletes B cells, so you can't make antibody, but you could make antibody anyway, and it contains antibodies to all different kinds of organisms. So the infection risk in that case is not super high. Some of the, as you go from some other medicines that may have different effects on the immune system, you may have more problems with infection. And that's why it's really important, to tailor the immunosuppressive regimen, not only to the condition, but the individualized situation that every patient has, where everyone's different. And so, for example, when we treat GLILD and we use two medicines, Rituxan and either mycophenolate or azathioprine, they are at risk. Patients are at risk for more infections. But if we monitor the lymphocyte count and the white blood cell count and keep in touch with our patients and make sure things are going well, infection risk hasn't been super, super high. In general, we don't find a big problem with infection, but it can vary depending on the immune deficiency.
Are autoimmune disorders and PIs hereditary?
Yeah, so for example, in CVID, as I mentioned, if you look at the studies to date, 10 to 30% of patients with CVID will have a mutation in a gene that we think causes the immune problem. So what about the other 70%? Is it 2 genes and we're not smart enough to pick it up? Is it 3 genes? Is it 2 genes and environmental influences? We honestly don't know. We think that, there is likely a genetic predisposition to this, but we are not clear on exactly what that other 70% of patients, why they ended up with CVID, and we can't find a gene. Now, with CVID, when you have more autoimmunity and more non-infectious complications, your chance of having a gene is higher. So we sequenced the entire genome in our patients with GLILD, and it's probably getting close to about 30% now, where we've identified mutations that we believe cause CVID. And so it depends. If you look at chronic granulomatous disease, except for a very small percentage, it's always a gene that causes it. So it depends on the primary immune deficiency and other factors.
If you have CVID and rheumatoid arthritis, and you have children who also have CVID, what are the chances that they too will develop the rheumatoid arthritis or any type of autoimmune disease that you may have?
Well, I don't know of any study that has directly followed patients with CVID and rheumatoid arthritis, but whether or not they would develop it later on in life. But we do know that things like rheumatoid arthritis and lupus do have a tendency to run in families, number one. And one of the things in those specific cases that would be important for everyone to know is, with our current technology, if we just look at all your genes, can we find a damaging gene that is associated with this? So in my opinion, if you have CVID and your children have CVID, everyone should be sequenced. And sequencing mother and father and sister and brother, and if you have an unaffected SIB, is really important in ferreting out and finding the gene of interest. So that's one of the cases. Personally, I think everyone with CVID should get sequenced, and that's totally different than what I said 5 years ago. It's just because it helps us when we know the gene now. And so
And you're talking whole exome.
I think it's perfectly fine to do the initial screen with less expensive panels. And if you get a hit, great, you're done. Okay. And we've done that for years and years. But if you don't get a hit, then I want to look further. I do. And so I think that's how we've discovered other genes.
And speaking of which, what about autoimmune neurological diseases? Do you see a lot of these?
In immune deficiency, I'm trying to, yes, you can. Okay. So probably one of the classic examples of autoimmune neurologic diseases that occur is in a CVID-like disorder. It's actually people that classify this disorders now call it more immune dysregulation, but would be patients, for example, with mutations in a gene called CTLA4 or a somewhat related gene, because when it's mutated, it causes the same problem as a CTLA4 deficiency. It's called LRBA. So in that case, CTLA4 is a protein that's expressed on T cells once it sees antigen. So it sees T cells see antigen, they get ready to kill, they start to proliferate. But if you're going to put on the gas at some time, you got to put on the brake. And CTLA4 is part of the brake. It signals inside the T cell to settle down. And in those patients, they get central nervous system disease quite frequently. And in our paper that we published in the JACI, you could see an MRI of a patient that has CTLA4 deficiency that was pretty bad and pretty much completely resolved with treatment. So they do occur. I would say CNS disease is one of the more common problems, but depending on the mutation, it sort of depends on what the gene is. Hence, this is why it's so important for us to know what the gene is, so we can anticipate these problems and know how to treat them.
And very quickly, somebody had asked, what does immune dysregulation mean? If you can just touch on that real quick.
So I view remember, there are autoimmunity is when you make an immune response to some antigen, like some of the autoimmune endocrine stuff that we see, autoimmune thyroiditis, for example, or things like that, pernicious anemia. Sometimes you have an immune response that we don't know the antigen. Like GLILD is the classic, and so sometimes people will just say, oh, well, that's immune dysregulation. Okay. Actually, autoimmunity is immune dysregulation too, but you have to have something to say to try to describe to people what it means. And so that's the way I would view immune dysregulation. It's sort of a general term to determine to say that the patient is having problems with regulating the immune system. It doesn't have to be autoimmunity. And I keep going back to CVID because autoimmunity is so strong in CVID. For example, lots and lots of patients with CVID have big spleens and lymph nodes that are large. And that sort of lymphadenopathy phenotype is immune dysregulation. It's not really autoimmunity, but we don't know why those lymphocytes proliferate like that and why they get big spleens. We don't understand that yet.
I'm looking, it says, would you show the page of Dr. Rudis's credentials again at the end? That will be included when you get the recording. So that and the resources that he has talked about and listed will also be available. Moving on. Sorry, I had it and then it was gone. Here it is. With both autoimmune disorders and PI, how do you find the best time to do vaccinations?
Well, for example, okay, let's just take someone autoimmune cytopenias, for example. Okay, most common autoimmune disease that we see, and if someone has autoimmune cytopenias, and you know you're going to use Rituxan, you obviously don't want to deplete B cells and then give them a vaccination. So we really, even with CVID and all, and others, we are encouraging patients to get vaccinations. Certainly with COVID now, what we know is there'll never be a prospective study on CVID and vaccination and does it convincingly decrease mortality? But when you look at retrospective studies, boy, it does look like it. And there have been reports from around the world on that. So the timing is everything. It depends on what immunosuppressive agent you're getting. And and so you gotta be careful. And these are complicated too. Obviously, if you have no platelets, you've got to treat it. So, what's the most important thing? You may have to vaccinate at a later date, but it's complicated.
Can autonomic flares be caused by an autoimmune disease? And if so, what?
Autonomic?
Mm-hmm.
I do not know the relationship between autonomic flares and true autoimmunity in PI. There may be a relationship. I haven't seen it,
Mm-hmm.
but rare is rare, and it happens. So
And
I
we are rare.
and so I can't answer that question.
Which AI conditions are most common for those with natural killer cell deficiency?
So true NK deficiency is incredibly rare. I mean, I practiced for 40 years and never saw it. And I worked at, first at National Jewish, where, at the time we were a national referral center. And then at MCW, we built a national referral center. And I never saw it. So they exist. They tend to be very rare. There is pretty strong data supporting, the risk of an NK cell deficiency. And they, tend to present with viral infections, herpes, things like that. But I'm not aware of in just an NK cell deficiency about autoimmunity, because it's just so rare. I've never seen it.
This person has ulcerative colitis and lichen sclerosus, as well as other skin and eye issues.
Yeah, yeah, I again, I've never seen an NK cell deficiency. The things that you mentioned, some are common in normal people, like in planus, it can be a real problem, and it's just one of those difficult things to treat. So, yeah.
Is hyperparathyroidism an automatic disease in CVID patients? I think they mean autoimmune.
Yeah.
Had a parathyroid removed, is there further treatment needed or just monitoring?
Well, you should talk to your endocrinologist about that. In general, hyperparathyroidism is not. Hypoparathyroidism may be in certain cases an autoimmune disease. And with hyperparathyroidism, if they get the parathyroid glands out, it generally is curative. But I am not an endocrinologist, so take that with 2 grains of salt.
Interstitial lung processes, are they more likely triggered by autoimmune processes or immune deficiencies?
So there are, if you look at interstitial lung diseases, it is a broad spectrum of interstitial lung disease. Probably the classic interstitial lung disease that occurs in normal people, immunocompetent people, is IPF, or idiopathic pulmonary fibrosis. It comes under a number of different names. And that's a disorder where they just get progressive fibrosis. People looked for an immune component to that for a long, long time. It doesn't seem to be an immune component. There are some treatments, but in general, it causes progressive fibrosis. In CVID, as I mentioned, we don't know or if there is an antigen. There's some data that suggests it might be an infection, but we don't honestly know. But we do know that if you treat it with agents that target both T cells and B cells, people get better. And that argues but doesn't prove that it may have an autoimmune component.
What are the AI disorders that are associated with decreased survival?
So way back when Charlotte talked in CVID, which is probably the best studied, again, it was listed on the slide. It was, certain forms of liver disease, like nodular regenerative hyperplasia, for example. Enteropathy, where people can't absorb food correctly and waste away. Interstitial lung disease, where in the past we had no treatment for it. I'm trying to remember what I'm missing here. Liver, GI tract, lymphoma, which is, everyone knows, if you have CVID, you're at risk to develop a B-cell lymphoma. And if you have a B-cell lymphoma, even though the treatment for that has just been great, tremendous advances, you would be at more risk. Again, I think the magnitude of these risks has changed over time. So it sort of depends. And with other PIs, it's going to depend on the specific autoimmune complication that you're looking at to determine risk and mortality.
Is there any research that lists all the different types of autoimmune diseases that have been found in patients with PI?
You mean a single article that sort of...
Or somewhere that would list?
I don't know of a single article that we're looking at. If we've got like 500 genes now that cause autoimmune diseases and immune deficiency and disorders of immune dysregulation. So I'm not aware of an article that talks about it. Each disease is got its specific problems. Like, XLA, they get more inflammatory bowel disease. CGD, they get more inflammatory bowel disease. Abicid, they get mucocutaneous candidiasis, but they also have problems with endocrine problems due to that. So it sort of depends on the gene. And a lot of times, because of the gene function, we can figure out sort of why they have their autoimmune complications.
So, sorry, there was one that I wanted. Here. I don't understand why giving rituximab would help with CVID. I was fine until I was given rituximab infusions, and now I have CVID because of the rituximab.
Okay. So, let's just start out with the definition of CVID, because this is really important. And it's important because we are trying to change what doctors do before they give Rituxan. Okay, if you get Rituxan for an autoimmune process or whatever it is that you're getting it for, like you have a B-cell lymphoma, it's really important to know if you have an CVID or a B-cell disorder before you get the drug. Because it's clear in some patients that get Rituxan, they never make antibodies again. They have long-lived antibody deficiency. So if you look at the currently agreed upon definitions of what CVID is, technically you cannot say that someone, if the diagnosis of CVID was made after administering Rituxan, you can say, I think it's CVID, but technically that is not CVID. So that's number one. It's a very, I know it's a very important point because we think you can get it without CVID, and those diseases or those problems are different. The second point is, well, why would it work in GLILD? Well, this is sort of, the value of research, because when we first started studying GLILD and CVID, no one was doing lung biopsies and looking at the cells in the lung that were causing the fibrosis. We knew there were granulomas, and I won't define what those are, but they're sort of angry macrophages. But it turns out that T cells and B cells are important in the inflammatory infiltrate of GLILD. And in certain cases, you can actually have more B cells than T cells when you take a biopsy and actually count the number of cells. So when I started out way back when, before I had gray hair and all the other stuff, no one knew how to treat it. So we used what the interstitial lung disease group was using to treat interstitial fibrosis, like IPF, and we started with azathioprine. We tried high doses of steroids. And then as we got more and more biopsies, it was sort of like a eureka moment. You're like, well, if there's T cells and B cells in the lung, why shouldn't we try to get rid of B cells and T cells in the lung? So, and we knew that the T cells in CVID that have this interstitial lung disease are what we call activated. And that means they're angry. They act like they've seen an antigen and they're growing and they're dividing. So you give rituximab to get rid of the B cells, and then you give one of these other agents that basically target rapidly dividing lymphocytes to get rid of the T cells. And it's been incredibly successful. Now, there is a question in my mind, is it possible that all you need is the Rituxan? Because there's been several case reports of just using Rituxan alone. Or maybe are there cases when you need both? And that's sort of where the field stands, in my opinion. We know that Rituxan and azathioprine and mycophenolate work. But, when I went to the NIH and wrote this grant and spent, we had all these centers enrolled. I mean, there's just no money, and they just, there's one thing that you can change is get the NIH to help fund more PIs and studies that we need like that to look at those questions.
And going back to that question, that's one of the things that the Immune Deficiency Foundation is working on, is educating rheumatologists to do the testing for a PI before starting rituximab, so that the person who actually might have CVID before they start rituximab will know that it is not from the medication. And that is one of the things that we're really pushing to educate. Do the blood work, do the vaccine challenge, then start the medication. Because like you said, once you start the medication, you can't go backwards.
Yeah, they're
Um,
really important.
right.
Really important.
So somebody has said, when you say CVID-like diseases, what does that mean? Which diagnosis other than CVID does GLILD/lung AI conditions have?
Well, for example, there are mutations. So CVID classically has been, where you have all these immune abnormalities. You don't have IgG. Your IgA is typically very low, and you have a poor response to immunization. And at least early on, we didn't know of many genes that cause this. Now there's been an accumulation of genes that can cause CVID. And when you take patients that have one of the mutations in one or more in one of these genes and have CVID, they may have more what people think is immune dysregulation. Again, I'll go back to CTLA-4 as an example, CTLA deficiency. If you have a mutation in a gene that's damaging, and it's an autosomal dominant, so you only need one copy of the gene to be affected, they generally don't make as much CTLA-4 in the T cell surface to dampen down T cell responses. And they have a variety of autoimmune and non-infectious complications, much, much higher than someone that has run-of-the-mill CVID without a mutation in that gene. CTLA-4 is now classified as an autoimmune slash autoinflammatory or disorder of immune regulation. I view this as just people want to put things into little packets, and it's good for doctors to have that. You can see, so oh, I have CTLA-4 deficiency. They're much more likely to have immune dysregulation. I got to be worried about that. But they also can't make IgG. Most can't make IgG. They have bad vaccination responses. They meet the criteria for CVID. So I just say they have CVID or CVID-like disorder. So there are other genes that are like that, NF-kappa B and a host of others. So that's why I do that.
Inverse vaccination, and describe what that is, please. And CAR T-cell new treatments for autoimmune disease are showing promise in clinical trials, but are they being used in PI patients?
I missed the first part of that.
Inverse vaccination.
Okay. I'm not clear on what that means. But CAR T cells traditionally have been used in cancer. I mean, that's really where most of the work is being done on CAR T cells. And so in case people don't know what a CAR T cell is, if we know an antigen, okay, for example, an antigen in a tumor that's made specifically by a tumor, like in melanoma or certain other cancers, there's a variety. You can identify a T cell that actually will recognize that antigen. And now you can put that T cell, you can genetically make a T cell receptor that will recognize that tumor antigen, and through other manipulations give it a growth advantage so that it will seek out the tumor and kill it. So CAR T cells, to my knowledge, are not being used at all in PI. And you know, uh, none that I am aware of. Let's just put it that way.
A lot of people with autoimmune disorders take steroids. So what are your thoughts on taking daily low dose prednisone long term? Is that something that is typical for autoimmune? Are there risks?
So in one, you have to define what low dose is, because low dose in a kid is different than low dose in an adult. I mean, the consequences on growth and everything else are different. In general, I think most people would like to get their patients off of steroids, okay? But sometimes you just can't. And so, it's everything in life on when it comes to this is a risk-benefit situation. If you're being treated with prednisone for an autoimmune complication, that there's no other treatment that is steroid sparing. Now, rituximab is a hugely steroid sparing drug for certain conditions, then switch drugs. But sometimes, you just have to be on prednisone for the long haul.
For patients already being treated for autoimmune conditions, and sometimes that is the red flag that leads to a PI diagnosis. For those such as lupus or other things, how does diagnosing a PI, how is it altered or otherwise impacted by the treatment for the autoimmune? So if they're being treated for an autoimmune disorder, how then are they diagnosed with a PI, and when should it be considered?
Again, it's complicated. So, for example, if you have someone on high doses of steroids and you draw for a long period of time, or for example, say you have a child that has bad asthma and gets put on and off steroids frequently, it can lower the IgG, it looks like, just as low as a patient with CVID. And furthermore, patients on high doses of prednisone, they're not going to have the same vaccination response in general as someone that's, not on prednisone. And there is a debate. A lot of the pulmonary doctors, are calling some patients that are on chronic steroids CVID. Their IgG is very low. And so it can affect the diagnosis. And again, I personally believe this is where the skill factor comes in. You need someone to know when to measure it. You don't, when to do the immune studies. And the other thing is time generally helps. So if a physician that's very skilled sees you once, that's just one chapter in a huge, library of life, right? And, over time, following you carefully, a lot of times it just becomes really apparent if you have a PI and it's not secondary to an immune suppressive agent.
Okay. Is there hope for stopping the progression of multiple autoimmune diseases once one has been found? So because you have one, does that mean you're going to have a lot more? And is there any way to stop them from occurring?
No, there isn't any a way that I am aware of right now to stop that occurrence. And if you have one, it doesn't mean that you're going to have more. So, there are a lot more patients that have autoimmune cytopenias than GLILD, for example. So it's really common. It's really common in CVID, and a lot of times nothing else happens. So, but there is no way. In certain conditions, if like in IPEX, for example, when you just have this incredible immune dysregulation, a bone marrow transplant will cure that kind of problem. But obviously, you don't want to have to do that for, autoimmune complications that are not life-threatening.
And then the flip side to that, is it common to be diagnosed with a PI if autoimmune deficiencies or disorders run in families?
I would say yes. So if you have a strong history of, autoimmunity in a family, you're probably at some risk that's probably small when you look at it globally, but there are certain instances where it may be much higher. And again, I just think these types of questions, like if you have a strong history of autoimmunity and someone then develops CVID or something like that, again, I just think now the cost of sequencing is so low in comparison to what it used to be. I think it's better to look at individual rather than to make just sort of general, sort of, well, you're at risk. Well, what does that mean? Then you get into all these things. But yeah, if autoimmunity runs in families, there would be the flip side of it. Immune deficiency would be more likely as well.
This is a question that comes up frequently. What is the best way to notify other specialists about AI concerns when they think it isn't likely that we'll have more than one uncommon condition?
Find a doctor that understands this and they can talk to him at a professional level. Honestly, I don't think that it's very difficult to sometimes as a patient to reach physicians and make them understand, these sorts of things. And you got to understand these are rare diseases. A lot of physicians maybe have seen one CVID patient in their entire career. Now they may have seen more and they just don't know it, but that's certainly a possibility, So I think, the other thing lies on us is to, present at general pediatrics meetings, national pediatric meetings, national internal medicine, family practice meetings, so that physicians are more educated and understand PIs better.
I would agree. I think we're going to, let me look one more time. I think we have time for maybe one more question. I am trying to get to those. There's no way we can answer all of them. And I encourage all of you, if we have not been able to ask and answer your question, to reach out to Ask IDF. And Emma's going to talk some more about that. But I've tried to pick questions that a lot of you have asked, and some of you have asked some very good questions. I'm looking to see if there's anything else. I think the last question that would be really good is, and I think I know the answer, but if you could go, we've talked about how do you get your physician to pay attention and to do the testing, but what type of physician should you approach first? Should you talk to your immunologist about your concerns about maybe having an autoimmune condition? Or what would be the most common specialists that you should see? For example, rheumatologist for a condition like rheumatoid arthritis, but what would be some of the other specialists that you should go and talk to if you have concerns about a specific autoimmune problem?
So just to clarify, and I just want to make sure I understand the question, does the person have a PI? And
Yes.
then, so yeah, frequently I would say, clinical immunologists will work with rheumatologists to help co-manage patients. So, but in general, as this talk is shown, we see a lot of autoimmunity in PI. And if you're a clinical immunologist, you've been around the block and seen a lot. So, one thing you could always consider is to get a second opinion, and maybe go, to a referral center that sees a lot of PIs, which, more and more, we've got more and more really good referral centers that see both children and adults. There is also, depending on the PI that you have, the NIH will provide free care for certain PIs, lifelong free care once you get into their system. So there are, if you feel stuck and you have a primary immune deficiency and you sort of think, I've got other things that aren't being addressed and you're sort of trapped, I don't think going to a rheumatologist is going to fundamentally necessarily alter what happens unless your immunologist has referred you to rheumatologists just to help co-manage, because they may be more experienced in using some drugs for rheumatologic problems. So you've got options. A second opinion is a right. It shouldn't be considered extraordinary. It should be your right as a patient to seek, other opinions.
I'm also going to put a big plug in for our Find a Clinician resource.
Yeah. Good point.
This resource started with trying to help the PI community find immunologists. Every day we get questions on, do you have somebody in such and such an area who's a rheumatologist, who's a pulmonologist, a gastroenterologist? So if you as the patient are out there and you have a fabulous physician who you are seeing, who is working with you, and you would highly recommend that to somebody else, please encourage them to get involved with IDF. They can go onto the website, they can create an account as a clinician, and they can get started. I can get them into the Finder and other people can know. So not only are they helping you, but they could be helping a whole lot of other people. So it's a matter of spreading the word and getting them involved. And the other part to that, like I said, is using Ask IDF. We are always here to help you answer any question that you have. So those are some of the resources. Dr. Rudis, I cannot thank you enough for an amazing evening. We have discussed a lot about autoimmune. It is a very complex, complicated topic. And I think you have done a fabulous job. And I thank you very, very much for taking your time to help us tonight.
Okay. Thanks, everyone. Take care.
And Emma, I will pass it back to you.
All right. Thank you so much, Colleen and Dr. Rudis, both for your time this evening. And thank you so much also to our audience for your engagement and your participation and asking such great, thoughtful questions. We really appreciate it. Before we close out, I'm going to quickly share some information about a few of IDF's resources and some upcoming events. So just bear with me one moment. Thank you. All right. As Colleen mentioned, we hope that you'll check out our website at www.primaryimmune.org, where you'll find resources, events, support services, and more. Everything is free to access, print, or have mailed to you. And we can also help you find an immunologist or PI specialist in your area with the Clinician Finder. If your question was not addressed during the program, you can submit your question to Ask IDF. Visit www.primaryimmune.org/ask-IDF, or you can give us a call at the 800 number on your screen. Our resource navigator will personally connect with you to answer your question or direct you to appropriate resources. A recording of tonight's webinar will also be published on our YouTube channel. We appreciate your patience, as it does take about 2 weeks for that upload to be recorded. And on our YouTube channel, you can also find past webinars and other educational recordings. Are you looking for ways to connect with others who are navigating life with a PI? You might be interested in joining one of our many Get Connected groups. These groups are free, virtual, and volunteer-led opportunities to connect with others with PI all over the US. We offer location-based groups or nationwide groups. And because the groups meet virtually, you're not limited to joining a group in your area. You can join any group, time, day, or leader that works for you. If you're interested in starting a group in your area, please email volunteer@primaryimmune.org to learn more. And as we head into spring, we hope you'll save the date for the next webinar in this series. Our next program will address travel and PI on Thursday, April 18th. Registration is open for the 2024 PI conference, which will be hosted in person at the Sheraton Grand, Riverwalk, Chicago from June 20th to 22nd. This event will feature 50 education sessions, connection opportunities, and the world premiere of our feature-length documentary, Compromised: Life Without Immunity. The early bird registration deadline is March 31st. Visit primary.immune.org/conference to register, view the agenda, watch the trailer, and learn more. Join us for the IDF Walk for PI kickoff as we jump into the 2024 walk season. Come learn about Walk for PI and all the new opportunities and tools to help you and your team succeed. Plus, just by registering and attending, you'll be entered to win one of several gift cards. Use the camera feature on your phone to scan the QR code and register today. And we'll be hosting Walk for PI events across the nation, as well as a virtual walk if you don't have an in-person location nearby. All of the locations are at a local zoo or science center or amusement park, and by registering and attending, you get to experience the remainder of the day having fun with your friends and family. We hope to see you there. Please note that we are currently revamping the Walk for PI website. It will be available and revealed during the Walk for PI kickoff on March 27th. In the meantime, you can plan and get excited for the 2024 Walk for PI season. If you've been wanting to make a difference for IDF but are not quite sure how, you can complete a do-it-yourself fundraiser. Make a difference and fundraise your way. From gaming to bake sales to workplace fundraising, the possibilities are endless. You can use your hobby and passion to make an impact on the PI community. Use the camera feature on your phone to scan the QR code and learn more. We want to once more thank our wonderful sponsors for their generous support of our education and community service programming. Thank you so much, everyone, for your participation this evening, and thank you again to Dr. Rudis. We hope to see you at our next webinar and at the National Conference in June. Take care and have a great evening.